So you got some blood work back. It says that your kidney function isn't totally normal. Today we're going to talk about what tests are done, what the normal values are, what your abnormal values may mean, and what are you supposed to do about them. Welcome to Talking with Docs. I'm Dr. Brad Weenie.
I'm Dr. Paul Zalzal.
Brought a
I'm
guest
Dr.
back.
Sanjay Pandeya.
Dr. Sanjay Pandeya, a nephrologist. He was a big hit on our channel. Lots of people really appreciated the information that he gave them about kidney disease. We'll link some of those other videos. And we're going to start today talking about your labs. So people get labs all the time. Never have we had more access to our own personal medical information. And people look at them and they're stressed out and they maybe don't have access to someone to explain it to. So that's why we brought you.
And labs as they pertain to your kidneys, basically,
Yes.
right? The kidney labs.
Right, yeah.
We've got the kidney king here.
The king of the kidney.
I love it.
I'm flattered, but I tell you, I think it is quite valuable that patients can see their own information, right? I think that they own that information, and it should be part of their normal sort of healthy living when they get lab work done to know what those numbers mean, and in particular for my world, what their kidney numbers mean. And sometimes it's tough to interpret, right? Because the lab puts out these numbers and you don't know exactly what they mean. And so I think what I like to do is just dissect some of that to be able to make sure that it makes sense to patients. So I think there's probably four particular numbers, three of which are labs that are important for patients to know. So the first one is what your GFR is. So GFR stands for glomerular filtration rate. The glomerulus is the head of each filtering unit in the kidney called the nephron, which is why I'm a nephrologist. It comes from a Greek term. It's the filtering head of that unit. But I think the GFR, you can otherwise think of it as your kidney filtration rate, and that's the easy way to think about it.
Ooh,
and so,
KFR, you might say.
Yeah, that's right.
Okay.
And so your kidney's filtration rate is calculated by a blood test called serum creatinine. Creatinine comes from your muscle. It's you metabolize your muscle to creatine, and then it goes to creatinine, and you pee it out. And if you think about like any plumbing system, if you have a filter within that plumbing system, when the filter doesn't work so well, things that otherwise get filtered build up in the system. So a higher serum creatinine has the implication that you have decreased kidney filtering function. What the lab does is it puts that creatinine into a calculation with your age and your gender, and it spits out the GFR, your filtration rate. And in the general population right now in Ontario, we have about 1 in 20 patients who have a GFR of less than 60, which would put you at stage 3 disease. So 1 in 20 Ontarians have either stage 3, 4, or 5 chronic kidney disease.
And so what would be normal? So if someone's like, you know what, I'm vying for a normal GFR. What would be normal be considered?
So normal would be between 70 and about 110.
Okay.
Well, it doesn't take much down there to get into the kidney disease world. If 70 is normal, 60 is trouble.
Right, and there's also age-related decline in kidney function. You lose about 1% per year after the age of about 30.
Okay.
And these are percents, or these are GFR?
When I say percent, it's the equivalent of what the GFR will put out. We use them interchangeably, but it's in mils per minute is how
These are
it's
mils per
calculated.
minute, okay.
So stage 3 chronic kidney disease is when you have a GFR between 30 and 60, and we kind of divide that in half. So 3A would be between 45 and 60, 3B would be between 30 and 45, and then stage 4 chronic kidney disease is between 15 and 30, and then stage 5 is less than 15. Okay. So you have about 1 in 200 of the population, or 0.5%, that have stage 4 or 5 disease.
And these would be dialysis patients, I'm assuming? Getting close.
Getting close to dialysis when you're about a GFR of less than 10. So the GFR is the first important number for you to know.
Okay, and so if it's really low, you're going to know it, right? You're going to know something's wrong with your kidneys, but you could be walking around with a 60 and not yet know it, perhaps.
Right, and so there are other things that you want to know to say, well, do I have kidney disease?
Okay, so 60 is the number to remember then for GFR.
60 is a key number, and I think the other thing that's really important is that if you are less than 60, the lab will flag it. It'll flag it as abnormal.
Yeah.
But if it's above 60, it won't necessarily flag it as abnormal. particularly if you're looking at patients who've had a decline in kidney function,
Okay.
even in the normal range. So if your GFR one year was, let's say, 90, and then the next year it's dropped to 70, you should say, okay, well, is there a reason for that? Was it dehydrated? Is there a medication? Is there something reversible?
That extra
So it's
large
important for
pizza,
you. Yeah, exactly. So it's important for the patient to know that number, because even that trend downward is important and might trigger a referral to someone like me.
Got it. Okay.
So that's the
GFR.
first number. The other number is something called the urine albumin creatinine ratio.
Okay.
It's something that we've seen, and it's been widely published, that it's probably an underutilized test. And the reason that it's underutilized is it's really significant in the kidney world and in the cardiovascular world.
Okay.
All right, so the urine albumin creatinine ratio is a measurement of how much protein you're spilling in the urine. You should really spill no protein.
Ideally, yeah. So albumin's made by our liver, primarily designed to transport some stuff and hold liquid in our vascular space.
Correct.
And then our body is very efficient at keeping it in our vascular space. But if it starts to leak out, this is a sign, hey, something's not quite right in our kidneys.
Exactly.
Okay.
And so the normal would be less than 3. It's in milligrams per millimole in SI units in Canada. So when you have an abnormal urine albumin creatinine ratio, we'll call it urine ACR, it has 2 implications. One is that you have some issues with respect to your kidneys, and there's some prognostic, it's a prognosticator for your kidney disease and how fast it might progress. So if you have existing kidney disease and you have a high urine albumin creatinine ratio, your risk of progressing is higher the higher your urine albumin excretion is.
Okay.
Okay. The second part is actually cardiovascular risk. So the kidneys are very vascular structure. These filters, 200 liters go through them a day. These 2 small organs that are about 10 to 12 centimeters.
200 liters.
200 liters a day. So they're very vascular structure. 1/5 of your heart's blood supply. So 1/5 of every pump goes through these kidneys.
Wow.
Like the needy child takes all the attention. from
That's
the
us.
heart.
That's us.
That's you, Paul.
Yeah. And so
Just as God made me.
So what happens is that the urine is seen as a window into your vascular health.
Okay.
Because when your vascular system is diseased and you get what's called endothelial dysfunction, you will spill some of that protein even at very low levels. You'll see that will come out. And it's important enough that now our cardiology colleagues are now advocating to measure urine ACR. So we've hit some prime time since cardiologists.
You know it's
Once the
important for
cardiologists are
cardiology.
acknowledging you.
If they're going to get out of bed for this one, something's going on here.
So I'll tell you the specifics of this. If you look at the ranges between going either lower in your GFR or increasing in the urine ACR, along that entire spectrum, your risk of coronary artery disease goes up, peripheral vascular disease goes up, hospitalizations for heart failure go up. The development of atrial fibrillation, which is the most common arrhythmia in adulthood, and about 4% of the general population in adulthood. So all of these things go up, along with your risk of developing acute kidney injury and progression of chronic kidney disease.
All from the UACR, the urine ACR.
All from the urine.
That's one powerfully predictive value.
It is.
One thing I think is important for people to know about the blood work is a single measurement we shouldn't freak out about, right? So there's some things that can cause your creatinine particularly to go up. So if you're really muscular, if you have had a hard workout, if potentially you take large amounts of a creatine supplement, because ultimately that's what gets broken down to creatinine, or if you're dehydrated, your fluid status can predict this. So we're really talking more about trends in nephrology and cardiology, would we not say?
That's right. So, so our guidelines would say that if you have an abnormal test, to repeat it within a couple of weeks.
Got it.
And see, and just to make sure it's confirmatory, because any lab test on any single measurement could be off.
And if I could oversimplify it for these 2 measures, so like you used that analogy of a plumbing system in your house with a filter. I recently changed the filters in my home, which was quite a job. So you have a filter. A filter can fail in 2 ways. 1, it can get plugged up. That's your GFR. 2, the filters can just fail and let everything go through instead of filtering stuff out. That's the urine ACR. Is that too oversimplified? Is that basic?
No, that's great. And I think if you picture this as a great analogy people have about a picture of a train, and the train's approaching a cliff.
Yeah.
Okay. And where you are close to that cliff, if that cliff is needing dialysis, is where that train is at that one moment in time. But how fast that train is going relates to your urine ACR. The more protein that you have in the urine, the faster that train's heading to that cliff.
Okay.
All right.
We need Superman here right away.
That's what the nephrologist is.
Right.
So the third number that's important, and it's now more important than ever because while we were using it in nephrology, it's now getting published on every lab report, and that's called the KFRE, which is your kidney failure risk equation.
I thought you were going to say KFC.
Yeah.
KFC could cause it potentially,
Yeah.
but I did not know that. Okay.
Yeah.
Okay.
And so you'll see that this is now calculated on every lab. So you'll see your GFR, and when you have a urine ACR study, they're able to calculate your risk of your risk of actually hitting end-stage kidney disease in the next 5 years.
And is it using those two values? It's using GFR
and your age.
Okay.
What does KFRE stand for again?
Kidney failure risk equation.
Okay, wow.
And so it gives you your 5-year risk of hitting end-stage kidney disease.
Wow.
In our world, it's important because we have certain referral criteria which we can talk about, and one of them is based on your KFRE. So that's the third number that you will read, and what you want it to say is 0 or less than 5% or whatever.
So a normal human's like around 0.
That's right.
Okay.
That's right. And then the other important number, which is not a lab test, but important for your kidneys, is blood pressure.
Okay.
Right? So blood pressure control is important. I ask my patients, whether it's home blood pressure readings or at doctors, what's your blood pressure? They usually say, my doctor said it was okay, nothing to worry about. And what we do is we say, what was the number?
Yeah.
Okay, can you tell? Because that for us is important in terms of.
And they don't really use,
therapies.
often they don't want to give you a number, right?
I don't think they don't want
don't know
to.
it.
It's just when your doctor says it's okay,
Fine,
or
don't ask.
you know, that if you measure it yourself, you tend to actually know your numbers.
Agreed.
Well, and it's easy enough to do. We made a video about doing it. It's so easy to measure your own blood pressure. And if you don't want to buy a kit, and a lot of pharmacies have it, just sit in a chair, put your arm in, and boom, you get your blood pressure.
Well, what's interesting, I'm sure you guys are the same. The American Heart Association has reduced their number now. They want it lower. I think we've tolerated, borderline high blood pressure for a long time, and they're recognizing, you know what, we gotta just keep getting lower.
Yeah, and it came about in a trial years ago called the SPRINT trial, and it was lowering blood pressures to as low as, let's say, lower than 120.
Yeah.
Whereas we were using 130, and the general population at home 135. And of course, there's certain caveats about who that might not be so good in with the blood pressure that low. But that's the other important number to know.
Well, so what do you feel? What's
your goal?
Say? What do you say? Get your blood pressure to this level.
So if you're diabetic, it should be less than 130 over 80.
Yeah.
Okay. If you have chronic kidney disease, our guidelines are that it should be less than 120 for your systolic and less than 80.
Yeah.
Okay. However, if you're an older population that have other prescription medications that might affect your blood pressure, you might get lightheaded when you stand up. These are all the caveats that for which we individualize therapy.
So just the average person watching this video, what do you think they should aim for?
At home, if they have no kidney disease, less than 135 over 85, while on therapy. Okay. All right.
Right. When you're not on therapy, you're just...
the lower the better.
Yeah, I was gonna say the take home is
the better.
as low as possible without getting dizzy, really. Like, because there's no downside as long as you're perfusing your organs, right,
if you
and not
stand up
passing
and
out.
fall down,
Too low.
just
Yeah.
right.
Yeah, and good thing is most people who aren't on any therapy don't do that, so that's good.
One other blood value, just to talk about quickly, that we used to always talk about in residency when we were training, is your blood urea nitrogen, or your BUN.
Yeah.
So I'm assuming that this is not as important anymore.
We use it. It's part of our normal panel that we measure. The urea will go up with decreasing levels of GFR. So we know that because your kidneys process and filter the urea out as well. We also use it as a marker for dehydration because when we evaluate it, if we see that your urea is up disproportionately to your creatinine, we say that that's probably a dehydrated state. There are other things that could influence urea. Any kind of protein, what we call catabolic state, or where you break down protein, can do it. If you were to have GI bleeding, then that's a source of urea that can put your urea up without any change in your kidney function. So there are other things, but as a single marker, we don't use it except in certain circumstances.
Brad's just asking because he used to like looking at his cereal BUNs and say, oh, look, I got nice buns. You can't do that anymore.
Oh man, and all it is proteins break down, and then there's that ammonia group that we got to get rid of. So that goes to your liver, gets packaged as urea, which is like CO and then 2 NH2s, and then that is a nice small molecule that passively just leaves into our urine.
Right.
Right, and then if it goes up, then we say, okay, well something's not quite right.
You're impressing me now.
There you go. You like it? Yeah, we like organic chemistry in this channel for sure. Okay, so
Our viewers don't, but
where does that leave us? So to your point, so now you've had a measurement, and say you've had 2 measurements now, say a month or whatever apart, and you're on the trend or the path to some type of early kidney disease. You talked about it a little bit. When do you say, hey doc, should I see a nephrologist? When's the time to intervene? When's the time to worry? When's the time to start changing some things?
Yeah, it's a great question. So there's certain triggers that the Ontario Renal Network, which is the governing body that handles kidney care delivery in Ontario, has certain parameters that suggest when you should be referred. So a lot of things, as you can imagine, are very adeptly handled by family physicians,
Okay.
right? So if you have minor kidney disease where, let's say, your KFRE is less than 5%, or if your urine ACR in a non-diabetic is greater than 30, or in a diabetic greater than 60, then you should be referred. Okay. If your KFRE is greater than 5%, you should also be referred.
Okay.
And then just straight out, if your GFR is less than 30, no matter what the KFRE calculation is, you should also be referred to a nephrologist.
And so when someone is referred to a nephrologist, there's things you can do to slow down this kidney disease progression?
Yeah, so I think it's important, and we talked about this in the last video, that leading a healthy lifestyle is very important. Eating a heart healthy diet, no smoking, avoidance of excessive alcohol use, which can influence your blood pressure, avoiding, if you can, anti-inflammatory agents, which I know we're going to talk about. But those are sort of lifestyle things you can do on your own. But in addition to that, when you see a nephrologist, we have a lot of things now in our armamentarium that we can use by way of our prescription pad to give you therapies that will help delay the progression in your kidney disease, and also, as we've talked about, improve cardiovascular outcomes.
Wow. Well, that was super helpful. For now we know how to look at our labs. We know how to compare them to previous ones. We know when we're getting in trouble and when we should come and see someone like you.
Absolutely. Now you know. Now you're armed when you go to your family doctor. Say, listen. Now I've been looking at my blood work. I don't like the trend. What should we do? And if you like this video, please like it, subscribe to our channel, share it with someone that maybe is a little bit worried about their kidney function.
And we really want to thank you for coming out and helping us. I love when we have guests that are so smart, and I just learn so much from this. And when I watch this video, I just put my thumb over my face and just listen to you talking. Sometimes I put a thumb over Brad's face
Wow,
too. Just
rude.
listen to the guests.
That's rude.
Thank you. Remember, you are in charge of your own health.
We'll see you next time.